Alright, hello everyone. Welcome again to another video in our playlist, endocrinology playlist. Today will be the last video in the endocrine playlist about diabetes. Let's dive in. So, whenever we bring diabetes in the table, we always think about a disorder which leads to hyperglycemia, and that is true, but not every hyperglycemia means diabetes. So we need to identify the cause of hyperglycemia before we diagnose patient with diabetes. Okay, so simply, as I said, it's condition with a high blood sugar, but not all the diabetes mean high blood sugar. Diabetes is a condition leading to a hyperglycemia because of problems with the insulin interaction with the cell, or because of deficiency of the insulin. Okay, we're gonna talk about this in detail in the coming slides. So a simple slide shows how general population know about diabetes, etc. It's because of glucose intake by the food, and the insulin is not working, leading to hyperglycemia. Comes here to the cellular level. We can see that we have right here specifically, that is the beta cell, and beta cell which is in the pancreas. Okay, so once the glucose interglycolysis happen, and then after we finish the TCA cycle, etc., and ATP generated, that ATP will be used to pump potassium outside of the cell. Okay, this regulation leads to calcium influx inside of the cell, and we know that calcium is used in breaking the vesicles, and once we break the vesicle which is containing the insulin would be secreted. Okay, why is important to know the cytology level? Because when we talk about anti-diabetic medication, some of them working in potassium channel, some of them increase insulin influx, and some of them, for example, work in the DNA level. Okay, so that's important here. And in the right side, that's how insulin works on also the cellular point. It's easy, makes sense that when the insulin binds to its receptor, that's the glucose enter inside of the cell. Let's carry on. So the prevalence of diabetes is increasing, as you see worldwide. It's around 537 million, and yeah, we have the treatment of diabetes, but every time it's increasing. Okay, so this is a epidemiological problem, and we need to control it, not only by treating the condition, but even preventing the condition from happening at the first sight. Okay, so it's important to know about the disease. Moving on to the type of diabetes, I want to mention something here. This is not the full list. That's a comprehensive list. It's important in board exams and in the endocrinology rotations to know those types of diabetes, but there is a more complicated list. There is other types which is mixed and genetic, etc. But knowing this list, it's more than sufficient, I think. So the most common one is type 2 diabetes, then type 1 pre-diabetes, which is not diabetes condition. Pre means before diabetes. Gestational, another talk, that's gynecology, rare genetic test, and drug-induced diabetes. We're going to talk about each one in details, but I want to just mention here in gestational diabetes, what is this condition? It's a impaired glucose test after 20 weeks of pregnancy. Okay, what does that mean here? So if the patient is pregnant and she used to have diabetes before the pregnancy, that's not gestational diabetes, that's either type 1 or type 2. But if the patient developed diabetes after 20 weeks since she's being pregnant, that's called gestational diabetes. Okay, so type 1 diabetes, it's in shortcut, it means a problem in the insulin production. Okay, and most of the time you'll find it is called insulin deficiency type diabetes. Why? Because of multiple etiology. The mostly is unknown, and that's which is the most common. Then comes the autoimmune disease, which is well studied and well discovered, and there's a lot of studies regarding autoimmune condition. Most of the time is associated with a glutamic acid decarboxylase antibody, so this is important in case of steps. If they ask you a common cause of type 1 diabetes is autoantibody because of glutamic acid decarboxylase. Okay, so what is happening here? The antibody will bind to the beta receptors in the pancreas and preventing them from secreting insulin. Okay, so they will not secrete insulin. Or it could be acquired deficiency, for example, patients who had pancreectomy, so they remove the pancreas because maybe of cancer, lesions, etc., or pancreatitis. And I want to mention this, that's important, specifically chronic pancreatitis. Okay, type 2 is the most common type, the most common one. Okay, this is specifically seen at older age, 50s and more, and this is mostly associated with sedentary lifestyle. So patients who takes a lot of fat or a lot of carbohydrate, they are more susceptible to get type 2 diabetes. Okay, and also that's actually was a misunderstanding in the or misconception in the last couple of years, that they thought that type 1 is more associated with the genetic condition, but type 2 is more associated with the genetic composition. Okay, diet, as we mentioned, and environmental. And type 2 start to increase in the young population because of let me say bad diet. In the last couple of last century, a lot of fast food was introduced to the society, fat, etc., which has led to increase in type 2 diabetes. Okay, but clinically, which is we still do, but clinically we still applying this rule. If the patient is less than 30 years, this is mostly type 1 diabetes. Type 1 diabetes. If it's more than 30, then think about type 2 diabetes. Okay, it's not always true, but most of the time that's how we diagnose in the clinic. Moving on to the symptoms, and that is important actually. That's how they present the case to you in exams, or that's how you see the case mostly in the clinic. If it's type 1, you will see those symptoms, okay, which is thirst, and a lot of urination, which is we call polydipsia, polyuria, also fatigue, blurred vision, and weight loss. And that's specifically those symptoms for type 1. Okay, you won't see this in type 2. In type 2, you mostly see acanthosis nigricans because of insulin resistant, and it's accumulated in the body, so it will work in other receptors in the body. And also you will see a macrovascular issues in type 2 mostly. Okay, microvascular complications, we have the most common 3 symptoms are retinopathy, nephropathy, and neuropathy. And now I want to mention is a important point. Whatever you discovered one of those pathies in a patient, you need to check for the other 2. Okay, so if I had a patient who had retinopathy, my next step will be checking the kidney, doing a GFR and creatinine test, and also albumin test. If the patient, for example, had nephropathy, I will check the neuro, so I will do sensation test to check if the patient had any long neuron problems. Okay, macrovascular, that's the most common. complications seen with type 2 diabetes, cardiovascular diseases, and stroke and hypertension. And I want to give you an information here. It's important that those issues seen with diabetes, for example, cardiovascular disease and stroke, or even nephro and neuropathy, those all because of the hypertension, okay? The glucose itself, it's not the problem. The problem is with the high tension affecting the kidney, affecting the vessels, and leading to stroke, okay? So here we can see this is acanthosis nigricans, a darkness of the armpit. Here also you can see it, and also you can see it is around the back of this patient, back of his neck. All right. So the diagnosis to diagnose a diabetes, first of all, before get along with the algorithm, the most important thing, and I believe, is to rule out medication side effects. Okay, med side effect. Why? Because maybe the patient is taking steroid, and steroids, for example, leads to a hyperglycemia. So once you stop the medication, everything gets back to its normal level. And here, steroid, it's the cause of the hyperglycemia. Okay, so always take care of this. You need to rule out any medication side effect. Then after that, diagnose diabetes if it's still the case. So how we diagnose diabetes, we have 3 tests here. Okay, the most used one are the first 2. OGT also we can use those, but not that common as the first 2. Okay, the important thing here that if you want to diagnose diabetes, you need to diagnose by using 2 tests. Okay, 2 times. And if you start, for example, using the fasting plasma glucose, you cannot repeat it again. You need to do this test, then the second time you do, for example, hemoglobin A1C. So let's say that the fasting blood glucose of the patient was 165 after rolling out medication. Then I cannot repeat the fasting blood glucose again. I need to either do hemoglobin A1C, which is, for example, let's say 8.1, or I can use OGTT, which comes, for example, a 300. Okay, so in this case, milligram deciliter here, milligram deciliter, and here percent. So in this case, I diagnose this patient as diabetic patient. Okay, you see this table how you diagnose diabetes. So if the fasting blood glucose is more than 126, and if the OGTT is more than 200, and the hemoglobin A1C is more than 6.5, boom, you have diagnosis of diabetes after rolling out a medication. Very important. Okay, and between the normal range to a diabetic range, that's what we call pre-diabetes, which is we already discussed. Those some drugs which can cause diabetes or mimic diabetes, which we need to rule out. There's a lot of drugs, but what I think the most important ones for the board exams are steroid, and also cyclosporine. In case of immunosuppressive, they always ask this. Thiazide, specifically hydrochlorothiazide, I think that's important. Hormonal, not so much important. And antipsychotic. Okay, for example, specifically clozapine and olanzapine. You need to know those. Okay, definitely they ask this a lot in the steps. Let's carry on. The treatment depends on the type of the diabetes. If it's type 1 or type 2. Type 1, since we have a deficiency in the insulin, so we go directly to the insulin therapy. Okay, but in type 2, the most important part is lifestyle modification. As we said, type 2 diabetes patient, usually they have a bad diet, sedentary lifestyle, eating a lot of fat, etc. So we need to compromise their diet and change it. For example, introduce a more healthy diet, and then if it didn't work, we can use oral anti-diabetic agents. So we're gonna talk about. For the type 1 diabetes, we said we use insulin, and there is 4 types of the insulin. There is rapid, short, and intermediate, and long. Okay, generic name, that's what they ask in the exams, but in a clinic, and I saw this a lot in the clinic, you don't use the generic name, they use the trade name. Okay, so it is important to know this and memorize it. It's super important. Not the trade name, you won't see this in the exams. You can see the generic name. Okay, and in general, in type 1 diabetes, we use 2 medications. We use rapid, we have the long one. We use the long one to mimic the basal dose, okay, which is stays for the whole of the day to kind of mimic the basal insulin. Okay, and for rapid, we use it as a bolus, which is before the meal. This is mimic the insulin, which is increasing in case you take a meal high with carbohydrates, etc. That's the regimen which is we use most of the time. Sometimes we can use intermediate also, but not common as the regimen I mentioned. This is how they work. The important is to know names, not the peak, etc. They don't ask this. Oral anti-diabetic, but the most important one is metformin. They always ask this. Keep this in your mind. That's the first medication we used in patient with type 2 diabetes, and then we can use metformin with other agents. I believe the most used regimen are metformin with oral GLP receptor antagonists, for example semaglutide. Also we use those in weight loss, which is we call Ozempic. This is the trade name for it. We can use also other agents like glitazones, or either the new ones with the SGLT2 inhibitors, and each one has its own indication and depends on the patient type, etc. But the last drug that you keep it, the last result, is the sulfonylurea. Okay, you don't start with sulfonylurea. Sulfonylurea is the last thing you use. Those are the drugs that we mentioned and its own side effects, etc. I think the important thing you should know is other safety issues. For example, the lactic acid, that metformin can lead to lactic acidosis in patients. That's why we stop metformin if we're gonna admit the patient. Or for example, GLP-1 can lead to pancreatitis. That is important. You should know it. They ask this in the exams. Okay, so that's important. Here, that's how we deal with patients with type 2 diabetes, and how to control their own diabetes. So if the patient has a hemoglobin A1C less than 7.5, then in this case we start lifestyle modification and only one oral anti-diabetic, which will be in this case metformin, for example. Okay, most of the time we start it. If it's everything was controlled and the A1C was less than 6.9 or 6.5, sorry, which is the normal, we continue the intervention. If the A1C start to increase, then we do a dual therapy. So for example, metformin plus GLP agonist. Okay, if the target is hemoglobin A1C less than 6.5, we continue. Otherwise, if it's start to increase and there is a hemoglobin A1C more than 9, then we start insulin. And some of you will ask me like how we give insulin in type 2 diabetes. Here we try to do our best to make the insulin work even with a resistance. We give a high dose, trying to decrease hemoglobin A1C. Okay, so this is important. They may bring a case with type 2 diabetes in the exam and ask you that they give you hemoglobin A1C more than 9. They ask you what's the next step. Insulin, not oral anti-diabetic. Okay, common question in the exam, especially in step 2. How we prevent? Of course, we start with healthy diet, and exercise and weight control. And guys, don't forget this, that's important for type 2 diabetes. If they have a hemoglobin A1C of 7 or less, and they start to have type 2 diabetes, the first thing will be lifestyle modification. Okay, that's important. We have some acute complications, which is condition C. What do we call it is emergency conditions. In case of diabetes, there's two conditions, DKA and HHS. DKA is diabetic ketoacidosis, and HHS is hyperglycemic hyperosmolar syndrome. We had a case study, is already posted in the channel. We talked about DKA, but in general, DKA is associated with type 1 diabetes, and HHS is associated with type 2 diabetes. And the problem is in the specifically in DKA is the increase in ketones. Okay, but in type 2 it's because of high glucose, and sometimes they reach thousands, leading to a hyperosmolar condition. The most important treatment on those two conditions are IV fluid. So if they bring a case in the exam, it looks like DKA, for example, they had a high ketones, high blood sugar, and then they ask you what's the next step, first thing all is IV fluid. Don't give insulin. Insulin is not the key, it's not the key here. You need to start IV fluid, hydrate the patient, and give them a good blood supply, then you give insulin, and most of the time is the regular insulin. Okay, and then you observe potassium and you follow up, and your aim will be potassium more than 5. Okay, the last guideline suggested that potassium should be controlled between 5 to 5.5. The one before it was 3.5, which is the normal value, but the last guideline said you need to control between 5 to 5.5. Okay, here's a table, shows the difference between DKA and HHS. You can read it. And this is the end of the video. Thank you all for listening. If you have any question, you can write it in the chat box down in the comments, or send it to my email. Thank you so much.